is Hannah Couch, and I'm a student at Jacksonville University. This is Nursing 521, and I'm going to be presenting on the nursing grand rounds, talking about a post-op complication following a lumbar laminectomy. So this is a case study. We're going to be looking at nursing considerations, and for whatever diagnosis that we're going to conclude to, we're going to talk about the early recognition and key interventions. So, I'm going to be presenting a case study on a fictional patient who just underwent a lumbar laminectomy L4 to 5. This is a common surgery. As with all surgeries, complications exist, but we need to know what the surgery is. So this is a surgical procedure that involves removing a portion of the lamina, which is a bony arch that covers the spinal cord. So this surgery is most often performed to treat spinal stenosis, a narrowing of the spinal canal that can put pressure on the spinal cord and the nerve roots and cause lots of issues for the patient. So let's talk about our patient. Our patient is a 65-year-old male who underwent an elective lumbar laminectomy at L4 to 5. He was experiencing that spinal stenosis. So the surgery was uneventful, and the patient was discharged home on day 1. So post-operatively on day 2, he started to develop a headache that worsened when he stood up or sat. He also reported a clear, watery discharge coming from his incision site, in addition to neck stiffness, nausea, and vomiting. So my question to you are, what assessment findings would you expect the patient to exhibit in addition to those? So on physical exam, the patient had the following findings. We found that he had orthostatic headache, which was worse when sitting upright. He had neck stiffness. He had Kernig's sign, which is pain in the hamstring when the neck is flexed, and Brudzinski's sign, which is flexion of the hip and knee when the chin is pushed to the chest. But his neuro exam was normal. Let's talk about our differential diagnoses. So what are we thinking? We're thinking spinal fluid leak, possibly, serous drainage from the incision site, infection, pseudomeningocele, perhaps meningitis or arachnoiditis. So what diagnostic tests would you order to rule out these differential diagnoses and help us narrow this down? So the patient had a CT. It was a CT scan of the spine that was performed, but it showed no evidence of a hematoma or an abscess. A CSF analysis was also performed, which revealed an elevated protein content. And of course, a CT scan of the lumbar spine with intrathecal contrast and a lumbar puncture. So that low CSF pressure on the lumbar puncture was a finding, in addition to evidence of contrast leaking from the spinal canal on CT scan. So based on the patient's clinical presentation and diagnostic findings, we can conclude and narrow down that our diagnosis was a spinal fluid leak following a lumbar laminectomy. So it's a spinal fluid leak is a condition in which the CSF, or that cerebrospinal fluid, which is that clear fluid that surrounds and protects the brain and the spinal cord, leaks out of the spinal canal. So this can happen due to a dural tear, which is a tear in the dura mater, the membrane that surrounds the spinal cord and the nerve roots. So if we go back to our assessment, we can dissect it now and put together some of these puzzle pieces. Let's reflect. So our patient complained of a headache, which was worse when sitting upright. This is called an orthostatic headache. So when the patient sits upright, what's happening is that CSF pressure in the spinal cord decreases, or the spinal canal decreases. So this can cause a CSF leak to enlarge and put pressure on that dura mater, which is that membrane surrounding the spinal cord and the nerve roots. So all of that pressure can cause a headache. And then he complained of neck stiffness. So this happens when that CSF leakage irritates the meninges, that membrane that surrounds the brain and spinal cord. So this irritation can cause neck stiffness. We had a positive Kernig sign. So that's also a positive sign for meningeal irritation. So it's thought to be caused by stretching of the inflamed meninges in the spine. And then a positive Brudzinski sign. And it's another positive sign for a meningeal irritation. So it's thought to be caused by a reflex contraction of the muscles in the legs to protect the spinal cord from further irritation. So it's a protective measure. And then we can talk about his normal neuro exam. So is that something that we would expect to find in a patient with a CSF leak? Well, it's actually a normal neuro exam does not completely rule out a CSF leak. So it can be caused by a variety of neuro symptoms like the headache and the neck stiffness and the weakness and maybe some sensory changes. However, the severity of these symptoms can vary depending on the size of the leak and the location of the leak. So now we can kind of dissect and put together the puzzle pieces for our differential diagnosis. We can go back in time here. So let's think back. We thought of a spinal fluid leak, and then we thought of serous drainage from the incision site. So this is a less likely diagnosis because the patient's headache is orthostatic and he's got other signs of meningeal irritation. And then we thought of infection. So this is a good possibility, a good train of thought, but the patient doesn't have a fever or other signs of systemic infection. Pseudomeningocele, and that would be a collection of CSF outside of the spinal canal, and it can cause a headache or other symptoms similar to a CSF leak, but it's just less common. And then we thought of meningitis, which is an inflammation of the meninges. So that can cause a headache, neck stiffness, and it can also cause a fever. And this patient did not have a fever. And then we thought of arachnoiditis, which is an inflammation of the arachnoid matter, which is one of the meninges. And that can cause a headache and neck stiffness and other neurosymptoms, but also it's just much less common even than meningitis. So now we can talk about our nursing interventions. So the patient was initially managed conservatively. The patient was instructed to be on bed rest. We educated on the importance of hydration. We administered caffeine and analgesics, and he was also given some antiemetics for his nausea and vomiting that he was having. But if all conservative treatment fails, other treatment options can be considered, such as an epidural blood patch, which is basically where we inject the patient's own blood into the epidural space, the area around the spinal cord and the nerve roots, and that causes a seal to occur. The blood clots and helps to seal that dural tear. And then, of course, I think the most common that I see on at least my unit is we go back in and surgically repair that dural tear. Let's just talk a little bit about, we kind of talked about this already, how we can prevent it is intra-op, just being, meticulous and careful of that dura area, and then we talked about bed rest and hydration, and we want to instruct our patient to avoid lifting heavy objects, and then we're going to talk more about the pharmacological management. So first of all, of course, we're going to treat our patient, we're going to treat that pain, so we're going to use analgesics. NSAIDs and Tylenol are most commonly used to manage that mild to moderate pain associated with CSF leaks. So this will help the patient have relief from those headaches and discomfort. And then we're going to administer, sometimes doctors will administer caffeine. How odd, but it's got mild vasoconstrictive properties, so that can help reduce that intracranial pressure and minimize the CSF leakage, actually, especially when it's integrated into a comprehensive treatment plan alongside other modalities. So we're also going to treat with antiemetics because this patient was having nausea and vomiting. So drugs like Zofran and Reglan are valuable in treating nausea and vomiting. And then most often on my floor, I'll see the doctor ordered a hydromorphone pain pump so the patient can have independence and control over their pain. So what it is a pain pump, and it delivers hydromorphone or Dilaudid directly into that intrathecal space, and it's a more targeted approach for providing pain relief in cases of severe headaches associated with CSF leaks, especially when Tylenol or NSAIDs just aren't cutting it. So now we can talk about our outcome of the case. So our patient responded well to the conservative treatment. His headache and other symptoms gradually resolved over the next few days, and we took a repeat CT scan, and that confirmed the closure of the CSF leak. The patient was discharged home on post-op day 7, and we educated that patient to continue bed rest and to avoid strenuous activities for several weeks. So my question to you now is, what are some key takeaways from this case study for nurses who care for patients with CSF leaks? Have you ever had a patient with a CSF leak, or have you ever cared for a patient that had back surgery and experienced post-op complications? What were they? And overall, what were your thoughts on this case study? I look forward to hearing all of your feedback. Thank you so much for your time.